So, hello. We are going to have a little bit of a think about chronic kidney disease in this session. So, at the end of the session, we really want you to be thinking about the main causes of chronic kidney disease. We're thinking in the developed world at this point, in the UK specifically, and also the pathogenesis of chronic kidney disease. So, the disease processes that are occurring. So, doesn't really matter what the cause of the CKD is, but the progression and the pathophysiology behind it are actually very, very similar. And again, a key thing that you must know before looking through this or listening to this is that you need to fully understand what the kidneys do, how they function. Because if you don't know that, understanding chronic kidney disease is really quite challenging. So first of all, just a little revision question for you to start the day. So I'd like you to press pause, have a read through this question, and then I will go through the answer. So press pause. Okay, so a 50-year-old man is taken to the emergency department after experiencing severe dehydration. His kidneys are actively conserving fluid to maintain electrolyte balance through hormonal regulation. Which kidney function is primarily responsible for this response? So is it A, B, C, D, or E? Hopefully you wrote C or chose C, increased tubular reabsorption in the distal tubules and collecting ducts. The question is asking about what changes are occurring through the hormonal regulation. So we're acting on the end stages of the kidney to reabsorb both water and sodium. So sodium through one hormone and water follows that, and then water through another one. And the key question is, what are those two hormones that are acting at the end part of the nephron? So hopefully you say antidiuretic hormone, or you might know it also as vasopressin. So that's involved in the reabsorption of water in the collecting ducts. And then you've got aldosterone is the other one acting on the distal tubules, and that is involved in the reabsorption of sodium, and water follows that osmotically. So in both cases, we're getting a reabsorption of fluid from the filtrate, meaning we're trying to upregulate or improve the amount of blood volume that we have, and at the same time, the amount of urine that you produce will obviously be significantly reduced. So next question. Now, you may or may not know much about blood gases. That's absolutely fine either way. You can still have a little bit of a workout at this question. So I'd like you to press pause, read through this question, and then we shall go through it. But again, if you haven't done blood gases, it doesn't matter. Try and have a listen. I'll try and explain things in a reasonably basic way. But if you don't fully understand it, go and listen to my other resources on ABGs, so blood gases and ABGs. Okay, so a 50-year-old patient with CKD stage 4 goes to the renal clinic for review. Arterial blood gases, so pH is low, so we've got a buildup of hydrogen ions. CO2 is low, and bicarbonate is also low. So what this is telling us is the patient is acidotic. So we now need to know, is that acidosis because of respiratory cause, so CO2, or a metabolic cause? So we look at the bicarbonate. Always want you to think of CO2 as being an acid. Okay, this is explained in ABG sessions, but CO2 is an acid. So the CO2 is low, which means actually there's less CO2 derived acid. So that doesn't look like it's the cause of the acidosis in this case. The bicarbonate is low, which means it's being depleted because it's buffering those hydrogen ions. So that, a low bicarbonate, is suggestive of a metabolic cause of the acidosis. So this is telling us that it is a metabolic acidosis. What's the primary compensation in response to this acid-base disturbance? Well, it's a metabolic acidosis. So the respiratory system compensates, and it compensates by blowing off carbon dioxide. So hyperventilation. Has that happened? Yes, it has happened. CO2 has been blown off because it is now low. So we have got respiratory compensation for a metabolic acidosis. Is this compensation full compensation or partial? It is partial compensation because the pH is still in the abnormal range. It is out of the reference range. It would be full compensation if the pH was back to normal. Why does this occur in CKD? Well, thinking about what the kidneys do, the kidneys excrete hydrogen ions and they regenerate bicarbonate. If you've got chronic kidney disease, you cannot excrete as much hydrogen ions, so they build up, and you cannot regenerate as much bicarbonate, so that drops down. So that's the reason it occurs in chronic kidney disease. So let's have a little bit of a think about chronic kidney disease itself. What's happening? Well, you're getting progressive and irreversible destruction of the nephrons, so the kidney structure and function. And that will potentially lead to serious morbidity and mortality if not well treated. And so you're getting a deterioration in all the functions of the kidney. So filtrations, the formation, so that's your GFR, your reabsorption of useful things, and your endocrine functions. Remembering, of course, that there are lots of hormones that act on the kidneys, but also there are hormones or a hormone that is released by the kidneys. So what are the main causes of chronic kidney disease in the developed world? So I'd like you to press pause and have a little bit of a think about that in this case. So main causes, so about 30% is down to diabetes mellitus. So remembering diabetes mellitus is a buildup of blood glucose, and that chronic hyperglycemia damages glomerular capillaries, and that over time leads to what's called diabetic nephropathy and progressive loss of kidney function. You've got hypertension. So long-standing high blood pressure causes narrowing and scarring of the renal blood vessels, leading to a hypertensive nephro for nephron sclerosis, so scarring, and that again reduces filtration. You've got glomerular disease, such as glomerulonephritis. So, for example, you may get immune-mediated inflammation of the glomeruli. That damages that filtration barrier and leads to progressive kidney failure. You've got polycystic kidney disease, but that's a genetic condition causing multiple fluid-filled cysts that enlarge the kidneys and gradually impair their function. There are other conditions as well. So you might have obstructive conditions, so long-term blockage of urinary flows, for example, enlarged prostate or kidney stones. You may have chronic pyelonephritis, so that's repeated kidney infections, so they can cause scarring and gradual loss of kidney function as well. But the key thing is that the risk of CKD progression is strongly associated with a few things. One is the rate of GFR decline. So as your CKD progresses, the amount of filtrates that you make also declines, and that rate of decline is showing how rapidly CKD is progressing. Also, it's put in terms of blood pressure control, so poorly controlled hypertension accelerates kidney damage. And then the level of proteinuria is also really important, because the higher the level of protein in the urine, the greater the amount of glomerular damage has happened, and therefore it predicts faster progression. So what's actually happening? Remembering, of course, we've got about 1 million nephrons in each kidney, okay? And in the UK, which has got about a population of about 70 million rather, about 7 million have chronic kidney disease. 50% who are in the later stages when symptoms are just about starting to kick in. So at stage 1, you get kidney damage and you may have a normal GFR, or actually even you may in some patients see a slight increase in GFR. And we'll talk about why in a second, but the kidneys have significant renal reserve, and they can also undergo what's called hyperfiltration and compensatory hypertrophy. So that's why that GFR, even with a bit of damage, can stay normal or even go up a little bit. You go into stage 2, there's a mild drop in GFR down to 60 to 89. You go into stage 3, there's a moderate drop. So GFR is down to 30 to 59 mils per minute. This is where symptoms may start to kick in. Okay. And in stage 4, this is where we've got a severe decrease in GFR. So the GFR is down to 15 to 29 mils per minute. And this is really where the symptoms do start to kick in. So the classic symptoms that we'll talk about in a second of chronic kidney disease will be kicking in at this point. And then finally, in established renal failure, also known elsewhere as end-stage renal disease, your GFR, your filtration capacity is really, really low. So most patients at this stage require renal replacement therapy, or dialysis and transplant as well are possible consequences. So a key thing about this whole process is that progression is associated with many common processes. Doesn't matter what the initial disease is, whether it's diabetes or hypertension or other causes, progression is fairly consistent. And in that progression, you get a loss of functioning nephrons. Because you're damaging the kidney, the nephrons are starting to die. And that leads to a drop in GFR. And initially, at least, you get a compensatory hyperfiltration of the remaining nephrons. So the remaining nephrons increase the filtration rate to compensate for the loss of functioning nephrons. And this occurs because there are those fewer nephrons that are available must filter the same blood volume, leading to increased pressure and increased filtration in those remaining glomeruli. That increased pressure and workload in the glomeruli makes the filtration barrier more permeable and prone to damage, and that can therefore go on to lead to what's called proteinuria, as we talked about earlier. That damage to the glomerular filtration barrier allows proteins, in particular albumin, but also other molecules, to leak into the urine. Some of those other molecules that leak are inflammatory molecules that are in our blood all of the time, and they can become activated once they're within the kidney system, triggering inflammation in the tubules, leading to fibrosis and permanent structural damage. And that renal tubular scarring and the glomerular damage lead to a progressive renal injury, leading to a loss of nephrons, leading to a reduction in GFR, leading to this vicious cycle in the progression of chronic kidney disease. So what I'd like you to do now is kind of look at this table, and I'd like you to complete it. And I just want you to say for each of these kind of variables that are shown in here, whether they would go up, down, or stay the same in a classic chronic kidney disease. It's really important to note this is a generalization, okay? And it's also important to realize that as chronic kidney disease progresses and gets worse, the changes that we're going to talk about here will become worse, so become more evident and more obvious. But this is a great little generalization for you to link the physiology of what the kidney is doing in health to the pathophysiology of what is happening in a disease state. Okay, so I'd like you to press pause and have a look at the table and answer the question. Up, down, or stay the same? Okay, so we'll start with calcium. What happens to calcium? Calcium starts to reduce. And that is because vitamin D is activated in the kidneys by parathyroid hormone. Kidneys aren't working as well. Therefore, not as much vitamin D is activated. Therefore, less vitamin D is produced. And if less vitamin D is produced, there is less calcium absorption in the gut, because that's what vitamin D does. It absorbs calcium in the GI tract. So calcium goes down. What about phosphate? That goes up. The kidneys normally excrete phosphate, but because of the reduction in GFR, and also because parathyroid hormone action on the kidneys isn't as effective because the kidneys aren't working, and PTH secretes phosphate, the levels of phosphate rise. Remember, the kidneys aren't working, so aren't as responsive to PTH, and the GFR is also reduced. Hydrogen ions. So hydrogen ions go up because the kidneys can't excrete them as well, and bicarbonate ions go down because the kidneys can't regenerate those bicarbonate ions and can't make them. So both of those two things together lead or contribute towards a metabolic acidosis seen in chronic kidney disease. What about urea and creatinine? Well, in both cases, there is a reduced glomerular filtration, and that causes both urea and creatinine to increase. So you've got a drop in GFR, so therefore urea and creatinine start to build up in the blood. What about potassium? Exactly the same thing. Okay, GFR reduces, therefore reduced renal excretion leads to potassium retention and hyperkalaemia. What about vitamin D? Well, we touched on this a minute ago. PTH normally activates vitamin D in the kidneys aren't working, therefore vitamin D activation drops, and with less vitamin D, back to the calcium, less calcium absorbed in the gut. What about PTH? Well, this is important to understand. What drives PTH synthesis? Hypocalcemia. What have we got in chronic kidney disease? We have hypocalcemia because we can't make vitamin D, so therefore PTH levels start to go up. And so you have secondary hyperparathyroidism. So now we're going to think about some of the consequences of chronic kidney disease. And that secondary hyperparathyroidism actually links really, really nicely into mineral and bone disorder. Because as you hopefully know, PTH works in many different places. It activates vitamin D in the kidneys. But of course, kidneys aren't working here. But it also acts to reabsorb calcium in the kidneys, but the kidneys aren't working, and it acts to kick out or secrete phosphate in the kidneys, but the kidneys aren't working. But as that PTH starts to build up, it also acts on the bone and it starts to resorb bone. So we get an increase in bone turnover. And that's what this whole thing with CKD mineral bone disorder is about. So we're losing our nephrons. PTH isn't working as effectively, so phosphate is retained. That phosphate can lead to vascular calcification, so your blood vessels become calcified, and that accelerates atherosclerosis. The nephron loss means the PTH can't activate your vitamin D, so the decrease in vitamin D means we can't reabsorb or absorb as much in the gut, leading to hypocalcemia, and that hypocalcemia drives more PTH secretion, which is your secondary hyperparathyroidism, and that triggers bone resorption, and that bone resorption increases your fracture risk because you're resorbing bone, making it weaker. The hypocalcemia and the drop in vitamin D lead to decreased bone mineralization, and that is osteomalacia, so it's weakened bone through demineralization or less mineralization, increasing that fracture risk. The other thing that is happening, of course, is in CKD, we're getting a metabolic acidosis, and that acidotic environment starts to degrade the bone. So it demineralizes the bone, again, increasing that fracture risk. So there's the mechanism behind your mineral and bone disorder in CKD. So another nice little question for you. So I'd like you to read through the question and come up with the answer. So press pause, please. Read, have the answer in your head, then we'll quickly give you the answer. A 72-year-old man with stage 4 chronic kidney disease goes to the GP with bone pain and muscle weakness for the last 6 weeks. Blood tests show hypocalcemia and elevated PTH. What's the mechanism of this hypocalcemia? So without even looking at the options, you know he's got chronic kidney disease. You know in chronic kidney disease you can't make vitamin D effectively, and that drives the hypocalcemia. The hypocalcemia drives the PTH. So what is causing the hypocalcemia? It's a lack of vitamin D. What does vitamin D do? It absorbs calcium in the gut. So the answer is D, reduced intestinal calcium absorption due to vitamin D deficiency. So another consequence is hyperkalaemia. So the kidneys excrete about 90 to 95% of the potassium that people take in any one day, and the average person eats about 4 grams per day. The majority of potassium is intracellular, and if you remember from your basic cell biology, there's a sodium-potassium ATPase, and it helps to maintain cell membrane potential and multiple cell functions. So as 98% of ingested potassium is excreted from the kidneys, it is inevitable that kidney disease will lead to altered potassium homeostasis. And that can subsequently have adverse cardiovascular as well as other effects. So in hyperkalemia, it's a very common electrolyte disorder in chronic kidney disease and end-stage renal disease. And that's because the kidneys cannot excrete potassium as effectively because the GFR has declined, but also the distal tubular secretion of potassium also decreases because aldosterone is involved in potassium excretion in the kidneys. Consequences, so there are a variety of symptoms. It includes things like muscle weakness, paralysis, cardiac arrhythmias, and potentially cardiac arrest. If you're looking at an ECG, so an electrocardiogram, remembering, of course, what you've got your P wave, your QRS complex, and your T wave. A common ECG change is your peaked or your tented T waves that you can see in this one, or your widened QRS complexes. There are others that are present in hyperkalemia, but these are the more common two that you would see. So those are your consequences of hyperkalemia. You also get your metabolic acidosis. Now, we've talked about some of the consequences of that. We've talked about how it can lead to bone demineralization. It's important to realize that under normal conditions, the renal tubules are really important in reabsorbing huge amounts of bicarbonate every day, but also in getting rid of those hydrogen ions. And we produce a lot of hydrogen ions, and that's excreted and buffered as phosphate and as ammonium. So, of course, in chronic kidney disease, the kidneys can't excrete hydrogen ions effectively or generate sufficient bicarbonate for buffering. So therefore you drive or you get that metabolic acidosis. And that metabolic acidosis can have multiple symptoms on the body. It can lead to muscle wasting. It can lead to bone demineralization, lead to hyperkalaemia and tubular damage. What I'd like you to do is press pause and have a little bit of a think. Why is it causing muscle wasting? Why is it causing bone demineralization? We talked about that a second ago. How does it contribute or make the hyperkalemia worse? And how does it cause tubular damage? So just press pause and have a bit of a think about each of those before we go through it. Okay, first of all, muscle wasting. So what's a sign or symptom of that? Well, obviously it's going to be weakness. Okay, you lose muscle, you become a little bit weaker. And that's because the acidosis, the acid promotes protein breakdown in muscle, therefore reducing your muscle mass and causing that weakness. What about your bone demineralization? What will that do? Well, that of course leads to fracture susceptibility and bone pain. And we went through the mechanism of that a couple of minutes ago. So it's just the bone it normally buffers acid by releasing minerals. So it's contributing to that demineralization, bone pain, and increased fracture risk. What about hyperkalemia? It's a bit of a harder one, this. Okay, how does acidosis contribute to hyperkalemia? Well, the consequence is, of course, arrhythmia and ECG changes. But what you have in acidosis is you've got more hydrogen ions in the blood. So some of that hydrogen ion gets taken into cells throughout the body to be buffered by proteins within the cells themselves. But to maintain the charge at the membrane of the cells, something has to go out. So if you've got H+ ions going in, something has to come out, and that is K+. So potassium ions come out. So potassium ions leave the cells, and that makes that hyperkalemia potentially worse. And finally, tubular damage. Well, that, as we've already talked about, acidosis promotes inflammation and fibrosis in the kidney, and it helps, and therefore worsening nephron loss and causing further abnormalities in your UNEs, your urea and electrolytes that you measure during chronic kidney disease. So that's urea, creatinine, potassium, and sodium are the classic UNEs, or UECs as some countries call it. Okay, so patients with CKD will often have anemia and they'll get what are called uremic symptoms. Why do they get anemia? Well, that's quite an easy one to think about. You have to remember that one of the key functions of the kidney is to detect hypoxia, and it does that just by detecting the amount of oxygen in the filtrate. But of course, you've got less filtrate. You would normally be trying to drive more EPO production, but of course the kidneys aren't working. So they aren't able to produce as much EPO, and EPO, erythropoietin, acts on the bone marrow to make red blood cells. So therefore you get a decrease in red blood cell synthesis, leading to anemia and lethargy because you've got less oxygen transport around the body. Uraemia occurs as urea and other toxic metabolites that you would normally excrete start to build up. So urea, for example, is toxic. Ammonia is toxic. Urea isn't the worst. There are lots that are much worse, but it's called kind of uraemia because that's what we're measuring in our kidney function tests. And so because they start to build up, you get these common symptoms because these toxic metabolites are working on the nervous system. And you get symptoms like nausea and vomiting and lethargy, sexual dysfunction, cognitive impairment, and pruritus, which is itching. And that itching can also mean that patients will often have scratch marks because they're scratching the itchiness. So I'd like you to take a little look at this review question. It's actually very, very easy. Okay, it's really just asking what one of the primary roles of aldosterone is, but I want you to press pause, read it, and then we'll go through it. A 35-year-old woman goes to the GP for a routine checkup. Blood pressure is normal, no significant history. Lab results are, if we look through them, they're all normal. Sodium, potassium, urea, creatinine, GFR, bicarbonate, all perfectly normal. So this is normal. So what is the primary role of aldosterone in potassium homeostasis in this woman or anyone else in health? So is it A, B, C, or D? Hopefully, and I did mention it earlier, you said D. It stimulates potassium secretion in the late distal tubule and collecting ducts. So aldosterone does a couple of things. It works to reabsorb sodium and water follows osmotically in the kidneys, so it helps to maintain blood volume and blood pressure. But at the same time as reabsorbing sodium, it excretes either potassium or hydrogen ions, depending on the acid-base status of the body and on the potassium status of the body. So reabsorbed sodium kicks out potassium or hydrogen, depending on how things are sitting in the body, in the blood. So the last thing I'd like you to do is just complete this table. Really, we've already covered it. Okay, so it's just a reminder little table recognizing the kind of pattern that you see in a classic chronic kidney disease. So just what are the changes in the marker that you can see and what's the mechanism behind that change? So press pause and then we'll quickly go through it. Okay, so creatinine and urea, because they're both the same, they both go up in chronic kidney disease because there's reduced glomerular filtration and reduced clearance, so therefore those nitrogenous waste products start to build up. eGFR, so estimated glomerular filtration rate, that drops because the number of functioning nephrons drops, the amount of filtration you can do drops. Potassium, that goes up. There is reduced GFR, so less potassium is being filtered, and we take quite a significant amount in each day. And also, aldosterone action on the distal tubular portion of the nephrons isn't working as effectively because you've got chronic kidney disease. So 2 hits. 1, GFR, less potassium formed in the filtrate. 2, kidneys aren't working, so aldosterone isn't working to excrete it either. Bicarbonate drops, of course, because we get reduced renal acid excretion because the kidneys aren't working, they can't excrete acid, but they also can't make or generate bicarbonate, and that leads to your metabolic acidosis. Phosphate, that goes up because the reduction in GFR and the reduced action of PTH on the kidneys means phosphate excretion is reduced. Calcium is dropped because we can't make vitamin D, so therefore we can't absorb calcium in the gut. And PTH, finally, that goes up because the calcium is low, so that drives PTH secretion, and then therefore that acts on the bone and other places. That's called secondary hyperparathyroidism. Okay, guys, that is it. Thank you very much.